Okay, now we're live on that Facebook page.
Okay.
We'll just hope, because I'm using my phone to go on that page just to see if it's working. Since it's the first time that we're having that issue. Can you guys talk?
Yeah, can you hear me?
I'm here too.
Okay, so yeah, it is working on this Facebook page. So we're gonna start this podcast, and I'll be trying to invite them on this page instead. So let's recap. So I did the intro about pain management, but I did ask a question to Jeana. So the question was, when would medications come into play, and when dealing with pain?
Okay, so yeah, I was just talking about here to clear up some general or some common misconceptions about medications and give you a very general overview of certain pain medications. So I want to just kind of say that it's just because you have pain does not mean that you need a medication to take. It would be indicated if the pain is causing a disruption to your activities of daily living or your ADLs, or if it is really intense when you're trying to carry out those tasks. Another qualifier for using pain medication is if you've tried other non-pharmacological approaches. So I call this non-pharm. So every time I ever give out a medication, I always counsel about non-pharm measures as well, because drugs don't work on their own. They need to be coupled with different things depending on what you're using it for. So some non-pharm indication or activities you can do would be stretching, foam rolling, massage therapy, physio exercises, warm baths with Epsom salts. Maybe if you have a headache, drinking more water. Try those things first. And then if the pain is still persisting and you've done everything you can, then you may need a medication. So an example of this would be, say if you played a couple of hockey games and your legs are really sore, or you went a little too hard on push day and your chest muscles are aching. That's normal. It's okay to have some pain, and that can be alleviated with non-pharmacological interventions. However, if you're out jogging and you twist your ankle in like a gopher hole and you're limping, so that's interference with your ADLs, and there may be discoloration and swelling. So a medication along with these other interventions may be warranted. Or if you've had a headache and you have trouble functioning or can't think right, whether you're at work or at home, you've drank lots of water and you're still having this headache, then that may be okay to take a medication there. So you can see from these two examples that pain medications are never used alone as a sole therapy. They're only temporary solutions. And so treatment of the problem or the pain requires getting to the root cause, because the pain is but a symptom of what the issue is.
Sure. So when we talk about pain, most of us first think of the pain that we experience as the result of an injury. So broken bones, torn muscles, and ligaments. That is called nociceptive pain, and it is one of the types of pain that we experience. So any structure in the body that has a nerve supply can produce nociceptive pain when injured. That type of pain is easy to treat relatively with, typical physio, and sometimes in combination with short-term medications. So Jeana, what type of medication would you use for acute nociceptive pain?
Okay, so there's generally three types of medications we would use for short-term or as an as needed basis. So we call that PRN, as needed. So the first one is acetaminophen. So you commonly would know this as Tylenol. Tylenol is a name brand. Acetaminophen is a drug name. It comes in 325 milligram strength, 500 milligram, and then you can take up to two of the 500 milligram as one single dose every 4 to 6 hours when you need it. And with this one, it's very important that you don't go over 4 grams a day. So if you're taking 2 of the extra strength Tylenol 4 times a day, that would be the maximum. The problem with this is it can overload your liver. So that's why we don't want to take too much acetaminophen. You could be in trouble of overdose and toxic effects to your liver. However, when used appropriately, it's very safe It's effective for mild to moderate pain, and it can be combined with some of the other types I'm going to talk to as well. And it can also be used on a regular basis for more persistent chronic pain issues like osteoarthritis. This is a really safe drug because most people, even if they have other medical conditions, can take it, and it usually does not interact with any other drugs. So the second class that you may take acetaminophen with would be called NSAIDs. So these are non-steroidal anti-inflammatory drugs. So that would be your ibuprofen, also known as Advil or Motrin, your naproxen, also known as Aleve. There's also ketorolac, which is also known as Toradol. So ibuprofen, Aleve, those can be found over the counter. And then when you get in, there's many, many other NSAIDs that may be prescription strength. So some cautions with this one would be that it could be hard on the stomach, causing ulcers if you use it too much, or if you're prone to stomach ulcers or bleeding. It can cause some kidney problems if you have kidney disease, or if you are taking too much, or if you have a cardiac disease such as high blood pressure if it's uncontrolled. So those are some instances where I would do an assessment before saying, yes, this is a safe medication for you. So they all have different types of dosing schedules with each different drug. And these ones work by stopping the inflammatory process in your body. So when we're hurt, we release these inflammatory sensors throughout our body. And so this works to kind of shut those down. So it helps with swelling. So if you did have an injury that had inflammation and swelling, it would be appropriate to take. And you could take it with the acetaminophen for extra benefit as well. So the third class would be more for moderate to severe pain, and that would be opioids. So opioids come from the poppy plant, from opium, and they're derived into many different forms of varying potencies. So examples would be codeine, morphine, oxycodone, and some of them come already combined with acetaminophen, such as Tylenol number 3s. You have acetaminophen and codeine in the same medication, as well as oxycodone can be combined with acetaminophen, also known as Percocets or oxycosets. So these would be used for acute injuries such as breaks, if you were break a bone, severe sprain or strain, and maybe post-surgery. They're short-term solutions, and you use them only if you need them, if they can't be controlled with other means. So they come with a lot of side effects and cautions. So drowsiness, dizziness, impairment. So you might not want to be able to drive when you're taking these kind of medications. They can also cause constipation and respiratory depression. If you take them for too long, you can gain tolerance for them so that the same amount is not giving you the same effect. They work by binding to opioid receptors in our body, so that it's modulating our pain response. So it's not taking away any pain. It's just allowing us that we don't care about the pain anymore. So those are the three general ones we would talk about using for nociceptive pain.
But sometimes the pain continues long after the tissues are healed. Why is this?
Well, you're right, Francis, for sure. So most of the tissues in our bodies will heal within 4 weeks to 3 months after an injury. However, when our nerves, spinal cord, and brain experience pain for a long period of time, they become really good at feeling pain. The pain pathways from the tissues to the brain become very well greased, and we call that central sensitization. So for people who are centrally sensitized, the nervous system becomes very sensitive to pain, and the threshold for things that cause pain lowers. So for instance, these people will no longer be able to respond. Well, how do I say? Pain will no longer be a response to damaging stimuli. They may interpret the cold air from an air conditioner, pressure of clothing, or even really light activity to be painful, even though there's no way these things could actually cause tissue damage. So phantom limb pain, people have had an amputation, but they still feel discomfort in the removed area of their body. That's an example of central sensitization. And there are also less obvious causes such as fibromyalgia and some long-term joint pain like chronic low back pain, which are also examples of this phenomenon. So It's important to remember that a hypersensitive nervous system magnifies pain. So Francis, can I get you to show that picture of the brain picture for me, please?
Yes, I will do that for
Thank
sure.
you, sir. So we're going to show you a picture. This is what's going to come up here is a functional brain MRI.
Just give me
cool.
a second. All right, so
there we are. Yep, awesome.
Oh, it showed on the other screen. There you go.
Oh, they're wrong. There we go. Okay. Perfect. So the picture on the left shows the brain of a person while he is experiencing pain. So you can see the yellow areas are areas of the brain that have been activated. The picture on the right shows the brain of the same individual, but in the absence of pain. With persistent pain syndromes, it will take increasingly less provocation for those areas of the brain to light up, and then that person will, as a result, experience pain. So for people with central sensitization, the approach to treating them is quite different. We look at things like reassurance, education about pain, general whole body exercises like yoga and Tai Chi, and also functional goal setting. So we really encourage these folks, instead of focusing on being pain-free to be your goal, focus on your function. We actually avoid the things that people think of as being typical physiotherapy. We don't want to do a lot of hands-on stuff or very specific exercises targeting that area, because it actually encourages the brain to focus on that area even more. And, you know, if someone is centrally sensitized and we, you know, can say perpetually treat their knee, it's like the equivalent of changing a light bulb when the problem is actually in the fuse box. So we don't expect much success from that approach. So just a few general things, some pain information. So research has shown that the brain can produce pain and swelling even in the absence of injury to the body. So they've done some research, but they had people with, it was sore hands actually, and they had them simply think about doing hand movements. And in those folks, their hands actually swelled. So it's kind of interesting. Pain does not necessarily mean that something in the body is injured. Pain can persist even if the originally injured tissues have healed. All pain is real. And when we tell people they're centrally sensitized, we are not saying that you are crazy or you are making this up. Your brain is basically giving you unreliable information. All pain is experienced in the brain. So like we talked about with those folks that have the phantom limb pain, you can have leg pain without a leg, but you cannot have leg pain without a brain. The brain is very powerful, and if the brain believes something to be true, it will do everything to prove itself right. They did a study with burners that they made them look red, like stove burners, and had people touch them, and even though they weren't hot, they still felt that as a burn. So if you do something that the brain perceives to be dangerous, so after an injury, maybe that's forward bending or lifting, it will produce pain just to protect you, even if what you're doing is not actually injurious. Pain is an alarm system that warns the body of actual or perceived danger. So that perception part is very important. Thoughts and fears can increase our pain, much like they can increase heart rate, blood pressure, and muscle tension. So Jeana, for chronic long-lasting pain, what are some medications that we would use?
Okay, so that was really good overview and kind of might explain why there aren't a lot of medications that can help with chronic long-term pain. So the goal of the drug therapy is pain reduction and improved function, like you said, not pain elimination. There's no magic pill. Expectations and reasonable goals are very important. So a lot of people think that I'm going to take this and I'll get better. No problem. That's not the way it works. So in some chronic pain conditions, such as fibromyalgia, drugs are not the answer at all. The first line of therapy is non-pharm approaches. So exercise specialists or physiotherapist specialists, physiatrists, those people can make programs for people. So exercise, cognitive behavioral therapy, aquatic exercise, etc. In neuropathic pain, it's very hard to treat this. This would be something like sciatica or when a nerve is being compressed. So the two main classes of drugs that are utilized are antidepressants and anticonvulsants. So antidepressants can interact with different neurotransmitters that may help modulate pain, and the same is true for anticonvulsants. There's many different types of drugs and subclasses in these two categories. So I just don't have enough time to kind of go into the mechanism of action for them, unfortunately. Another topical medication that has shown some benefit and a low risk of side effects is a medication called topical capsaicin. So whenever you're putting something on your body instead of ingesting it, you're going to have less side effects. So capsaicin is actually derived from cayenne peppers, so it's really hot. And when you apply it to your body, it interacts with these vanillin receptors, which can interfere with the pain response. So the only kind of side effect that you might have with that is that you might, if you put on too much, you could get a sensitization a reaction on your skin. But overall, like the antidepressants and anticonvulsants come with a whole slew of side effects, as you can imagine. So it's really necessary to individualize therapy and to weigh the benefits and the risks. Jan, I think you might have a question for me.
So, yeah, I'm just getting caught up here. So sometimes my patients who have chronic pain ask about cannabis. As a drug expert, what do you think about its use and efficacy?
Okay, so that's a really good question because I get a lot of people that are just fed up because they may have unrealistic expectations, or they may have tried everything and they've tried all these different classes of drugs and they're not getting anywhere. Or they may not have, and they just want to jump to cannabis because there's a lot of information out there that talks about cannabis being kind of, you know, the heal-all miracle drug and that it's really effective for pain. So with cannabis, it's very similar to opioids, and then they don't solve the pain problem. They just interact with cannabinoid receptors in our body and make it so we don't care about the pain. So we're not getting down to the root. And then you can also develop tolerance. And when we talk about cannabis, there are a lot of side effects with that. So unfortunately, there's a lot of advertising and wrong information out there as it relates to pain. So it can be really difficult to discern what's good information and what is not. So there is a lot of research going on in this field. There are countless studies involving cannabis and pain. So I'll give you the summary of what all these studies, when they pull them together and do a systematic review of them, what they found. So they've concluded that there's no benefit for most types of pain from using various strains, all the different methods of using cannabis, THC or just cannabidiol or all together. So they think that, and as I mentioned, the list of adverse effects is really lengthy. So if you're not getting much bang for your buck, there's no point in putting yourself in risk. And also the adverse effects are not really suited for people in active military duty, because we know about the euphoria, the drowsiness, and risks of psychosis, and the list goes on and on. But, however, in a non-military setting, or if a member were on a PCAT or on the road to a medical release, there may be some small benefit when used for specific types of pain. So neuropathic pain, and particularly MS, so multiple sclerosis, when other treatments have failed. So it may be indicated as a third line after you've tried 2 other different types of treatment and have failed that, and the pain is still debilitating. So I wouldn't advise just going to the store and picking out something, because that would be self-selecting and self-medicating. And I wouldn't advise using the dry product to smoke, because anything that we're smoking and putting in our lungs can be harmful. So rather, I advise some people who do ask me about this, and I try to find an experienced physician team, which usually have an educational, qualified health professionals to tell you all about the medications. They will assess everything about you, your symptoms, if you have your thoughts, feelings, and attitudes, because it all plays a role when we're dealing with chronic pain, as well as other medical conditions, etc. There's many things that they go over so that they can choose an appropriate product for you. So the treatment is very highly individualized, and it may be changed several times as you find it needs regular monitoring for effect and for adverse effects to try and get the right product for you. So hopefully that gives you some more information about cannabis.
For sure. Francis, could you mind popping up those slides about sensitizing the nervous system for me?
Oh, sure.
Thank you very much. So I
And
just want to quickly go through, we talked about the central sensitization. So I just want to quickly go through some things that can make that worse and some things that can kind of help to aid it. Perfect. Thanks, Francis. So just quickly go through this. So some things that are shown in the research to sensitize our nervous systems and to set us up for more of a chronic pain state. So number one is stress and worry about pain. We also have the fear of not recovering. Sorry, is that? There we go. Yeah, so stress and worry about pain, fear of not recovering, life stress and anxiety. So even if our family and work situations are suboptimal, sometimes that can lead us down the path to chronic pain. Low mood and sadness. It's shown that when we're struggling with depression and whatnot, we feel pain a lot more readily. So again, the pain threshold lowers. And then we have legal and insurance battles, as well as anger, a sense of injustice, and blame. There's really interesting research a few years ago that showed that people who are involved in car accidents are much more likely to have persistent pain if they are the not at fault party. So again, that element of blame really can affect our recovery, interestingly enough, and set us up to be sensitized. Poor sleep can also prime the nervous system to be very sensitive. Negative self-judgment is a huge one, and you see it all the time where people will almost identify as I'm broken, or I have a bad back, I have a bad knee, and that negative self-perception of our bodies can really cause some problems. Extreme physical loading, such as high-level sports and heavy labor, as well as uninterrupted postures, and we talked about that a little bit in our first podcast about too much sitting, that can also set us up for some issues. Also medication and drugs, like Jeana talked about, a lot of medications do have side effects. Even things like nicotine and alcohol in our diet can set us up for problems. And other health issues sometimes prime the nervous system to give us grief. So diabetes, cancer, that type of thing. So the good news is that we do have some autonomy over some things that will calm our nervous systems. So setting clear activity goals is really important. Focusing on what you can do instead of what you can't. A sense of control over pain. So being actively engaged in your recovery and how you can contribute to that is really helpful. Physical activity also helps to desensitize the nervous system. So one thing that we'll often suggest are 1-minute movement breaks. So just a couple times throughout the day, as frequently as possible, really set a timer for 1 minute and do some non-threatening activity. So whether that's just some sit to stand squats out of a chair, or mimicking playing tennis, or what have you. So 1 minute a few times throughout the day, just to get you up and moving and to desensitize the nervous system, can be helpful. Really seeking things you enjoy. Pain is not the opposite. How do I say? The absence of pain really is pleasure. So trying to find things that you enjoy can really be helpful, even if there is some discomfort in that. Having a sense of control over stress and anxiety is really important. So sometimes, if people are struggling to achieve that equilibrium themselves, mental health professionals can be engaged to help with that. Time spent outdoors can help to soothe the nervous system. Practicing relaxation and mindfulness. A healthy diet and nutrition can also be a contributor. Working on fostering real social connections. By real, we mean not through a screen. And then also trust and acceptance of the body. So positive self-image, trying to even change the language we use. The whole I'm broken thing, just trying to get rid of that. And instead of I have a bad knee, I have a knee that sometimes gives me grief. That's a lot better way of looking at it, and a lot less limiting in terms of quality of life.
yeah, let's see if I did fix that.
That was some really good information, Jeanne. Thank you so much.
Yes, it is.
I can probably apply some of those.
I think we all can. It's kind of a tall order.
So every week we're trying to give like a prescription or something that you guys can do, and normally we do fitness and exercise, but I think these slides are showing like what we should do to improve our pain management. So that would be the prescription itself. And also, like Jeana said, always consult a health professional if you need more consulting or more information, individualized information about you. Also, I would like to talk about something. It would be like on this topic. It's when an injured person alters his or her movement pattern in response to the pain or dysfunction of a primary injury. The altered movement redistribute loads through the other joints in the body. So these changes in loading can generate injury remote from the primary injury in what is termed a compensatory injury. I hope I said that right.
That's very good.
Good job.
Yeah. So examples, I think Jeana has an example of a self-injury that, do you have an example to give us?
Yeah, I do. Like when you were telling me about this compensatory injuries, I was like, my brain lit up. I was like, oh my God, well, this happened to me. So I used to really love trail running, and I was trail running in the Cape Breton Highlands, and I tripped on a route, and I stumbled and kind of fell forward a little bit, and somehow that caused my pelvis to fracture. So I had an avulsion fracture in my pelvis. So I went through physiotherapy and reconditioning exercises, and I thought I was back to normal after, being non-weight bearing for a few weeks as well, and worked on it and did everything it prescribed. And so eventually I returned to normal, and I went away on a course, and there was PT and there was running. And when I was running, my foot started to really bother me. And I was like, oh no, I totally developed plantar fasciitis. So I went back to my physiotherapist and told her what I was experiencing. And she asked me, is it on the same side as your hip? And I said, yes. And she's like, I knew it. And so I had somehow thrown out my alignment when I was healing. And doing this running, I had changed the way I ran. And it caused my foot to be pronated or fall in, which caused that plantar fasciitis in the bottom with a lot of pain. So even though it was painful, medications didn't help me relieve that pain. So I had to use the taping, the stretching, the massage, and exercises to get to the root to solve the issue. So I was able to use some NSAIDs for a short duration. They weren't the solution. They gave me a little bit of relief. So the big, I think, take home is the non-farm with the farm. And I really agreed with and liked all of Jeanne's list of how we can take control back.
That's a really good example of your life example, because you did mention that you did develop a plantar fasciitis, and that would be the next topic of next week. So that's kind of interesting that you just bring that up today. Also, I don't know if anybody heard about the Dizzy Dean syndrome. If you never heard of that, sometimes you'll hear probably a physician saying this, so you have a Dizzy Dean syndrome. And that's exactly what Jeana just described. But that's a fun fact. Basically, where that started, it was from a Hall of Fame baseball player. He was a pitcher. His name was Dizzy Dean. And in 1937 All-Stars games, Dizzy Dean received a direct line drive on his left toe. Sadly, that broke his toe. So he actually tried to recover from it, but he came back too quick to the game. And during his return to play, he obviously changed his pitching mechanics because, actually your foot is still hurting. So he changed his pitching mechanics to accommodate the pain caused by the injury. And in doing so, Dean suffered a career-ending injury. Let me put that on the side. A career-ending injury to his pitching shoulder. So he was sadly a victim of a secondary injury or compensatory injury. Now, sometimes it's called the Dizzy Dean syndrome. So you might hear it from your doctor, and you know why they call it like that. So this is why the rehabilitation or reconditioning is very important. And also that when you hear us saying to you guys, don't compensate, there's a reason behind this. And the main goal is to regain full use of your body and actually also prevent that from happening again. So this is why when you see Jeanne, when you see me, is to technically we are working towards that. We are working to bring you stronger than what you were before. So it might hurt. It might not be fun when she's doing some manipulation on you. It's not a relaxation. It's to make you better, but it's worth it at the end. So I hope we're going to change the mentality of these treatments, but I don't think that's going to be that thing today. So I was looking on Facebook if you guys have any questions. So maybe we lost a couple people because of that, but we do have Amber Fur with us. And I will invite her right now in the party. Let's see where she is. Hello, Amber.
Hello.
Oh, we can hear you loud and clear. So I hope the Facebook will work. I'm really sorry about that glitch. We're going to find out what was it. But welcome with us, Amber. She's the sports and facilities coordinator here in Wainwright. And she does have quite a message to tell us today. So the voice is yours.
Thanks, Francis. Just thanks for letting me come here today. Just wanted to share quickly a little bit about what we have going on with sports. I know a lot of you guys are missing sports and maybe have been binge watching The Last Dance and have nothing else to watch. Every week I've been doing a CAF Sports at Home challenge on our Instagram and our Facebook page. And basically what we're doing is we're just taking a fun sports challenge and videoing it and posting it and challenging you guys to do the same. So you can find us on our Instagram page at CAF Sports Wainwright. And yeah, if we have time, could show you guys this last week's challenge. We did the foam roller toss, which was a challenge that Esquimalt had posted earlier in the week. So I will attempt to have that work.
And I did try it, and it's really, really hard.
I get a little fired up in it, I will say that.
You got to share your volume.
Weeks ago. So we are going to be taking a lacrosse ball and trying to get it into a foam roll. I'm winning a lot of luck on this one. Oh! Gotta have faith. Oh, for the love of all!
Not basketball.
Get angry. Stop getting it in! It's not fair!
I told you I could do it again.
Yes! That went in! That went in! I saw it! It ran in, it rimmed, but it went in. That counts. That counts!
It's your game, whatever you want. Let's doubt the last one. I don't know if it went in. What do you guys think on Facebook?
It 100%.
In and out.
It went in. Yeah, but it was in for a little bit. So that's all that matters because it took me a long time to get to that point. So yeah, if you're ever bored and want something to try, take a look at our Instagram page and try one of those. We've done a few like a Jenga tower with a golf ball trying to knock out a block, which is actually not that hard to do, and a few other ones. So also our Facebook page does a trivia night every Thursday. And this next Thursday, I'll be hosting a sports trivia night. So if you're missing your sports, this would be a great opportunity to get in and show off your knowledge or your lack thereof. So yeah, well, thanks, Francis.
I hope you guys are going to watch the basketball Michael Jordan documentary on Netflix because I'm pretty sure she's going to put question on that because she's a basketball fan. So I won't be surprised, but I'm going to prepare. I think I'm going to win this trivia. Just saying.
It's going to be a good one.
I hope.
Be sure to register.
Well, that's it today, guys. Really, again, sorry about that mistake on Facebook. We're going to try to find out what happened. I hope you guys really enjoy this knowledge about pain management with our special guest, Jeana Rogers. And obviously, if you do have any questions to us, don't feel free to just send it to us directly, and we're going to be more than happy to answer your questions. That include also Amber Fur, so you can directly ask her the questions, even the links for the Instagram or the all the links of the challenge that she will do. There's another one that will come up soon. I don't even know what that is, but I'll try the next one too. So next week it's going to be plantar fasciitis, and it's going to be with Jordan Leeming, our fitness and sports and recreation manager here, and obviously our normal guests, Gian and me. So I hope you guys are going to enjoy it, and if you have any question about that, let us know. We're going to be more than happy to answer during the podcast. So if you guys are shy or not shy at all and you want to come on Zoom, you can do this also. So on that note, I'm going to wish you guys a perfect evening. Don't miss the trivia night tonight, and see you next week.
Bye.
Bye-bye.